So we begin with the first teacher today, who will be Professor Susanna Price from London, and she will discuss the cardiac function essentials. Susanna?
Thank you for that kind introduction. So cardiac function essentials, for this I have no declarations or conflicts of interest. And what I'm going to try to do for you for the next 30 minutes is take you through three main areas. Firstly, to try and just revisit the basic physiology, which I'm sure we'll all remember. Secondly, to look at really a clinical and technical assessment related to perfusion, followed by a very practical approach to a differential diagnosis of shock. And then finally, to look at how vasopressors and inotropes influence cardiac physiology in a way that you'll be able to use practically in your ICU. I'm not going to give you a super high-end level about the latest evidence related to one inotrope or another inotrope or the latest in-depth physiological studies. What I'm going to try to do is give you a toolkit that you can use when you're working in the ICU to make your life easier. So to that end, by the end of this 30 minutes, I would hope that you should be able to discuss freely and with confidence the determinants of cardiac output. I would hope that you were able to list the causes and types of shock, describe clinical and technical assessment of perfusion in the shocked patient, outline a practical approach to the differential diagnosis of shock, and explain how inotropes and pressors work and what they actually do in cardiac function. So we're going to start with determinants of cardiac output. So in its simplest form, cardiac output is the volume of blood pumped per minute around the body. And in a normal resting state, in a normal sized person, it's about 5 liters per minute. Of course, it's more in certain states where the cardiac output and index go up, and it may be more or less depending on how big the patient is that you have in front of you. And the cardiac output is determined by the product of the stroke volume, that's the volume pumped out with each heartbeat, multiplied by the heart rate. And you can see from this that the stroke volume is determined by preload, afterload, and myocardial contractility. So let's explore those a little bit further. Again, at its most basic, here is the heart, and with contractility, blood is pumped into an arterial resistance, into a compliance. And the pressure at the outflow from the compliance, the mean systemic pressure, is determined by the elastic properties of the systemic circulation and the volume of blood. And most of the blood in the circulation is in the venous side. Now, the return to the heart, the venous return to heart, is determined by the pressure difference between this mean systemic pressure and the right atrial pressure. And it's driven and allowed by this gradient to determine the venous return. So that's your first determinant of cardiac output. When we think about then this preload, if you read the textbooks, they say it's LV wall stress at end diastole. And going back to what we all learned at medical school, it does actually relate to the overlap of the myocytes and the sarcomeres within the myocardium. And when you're looking at the preload and determining it for the purposes of trying to understand it in your mind, just think about an overlap of those myocytes. And as the heart becomes more and more filled, you increase the force of contraction. The things that will change your preload relate to your venous return, as we've just discussed, but also intrinsic cardiac factors such as your heart rate, the way the atria contract or don't, for example, in atrial fibrillation, both atrial and ventricular pressures during diastole, and the compliance or stiffness of both ventricles. So all of these things will determine what the preload is. Then when we think about intrinsic contractility, so this is your dP/dt of the ventricles, there are intrinsic effects that relate to optimal sarcomere overlap, but also extrinsic, which we'll come back to at the end of this half an hour, looking at sympathetic tone, catecholamines, both endogenous and exogenous, and also inotropes that you may use. There are also things that will reduce contractility, and these are really important when you're thinking about your critically ill patient. Yes, there are the normal adaptive physiological responses, but there are things that may be very abnormal in the patient in front of you that you should always take into account when you're considering the heart contractility. And it may be that you interpret an echo that somebody shows you or an echo report in this context. So hypoxia and hypercapnia are not great for the heart, in particular the right heart. Acidosis or acidemia is very bad for cardiac contractility. You may have endogenous cardiac disease or coronary disease, which may be known about or not known about, and electrolyte disturbance can profoundly affect contractility, as can many of the drugs that we use in terms of negative inotropy. So that's contractility. And then finally, we're going to step and look at afterload. So this is the impedance against which the ventricle must contract. Now that can be increased because of an anatomical obstruction. So from their left heart, for example, aortic stenosis, but it can also be affected by the systemic vascular tone, the systemic vascular resistance, which we'll talk about in a bit, also by the elasticity of the aorta and the ventricular volumes. Afterload can be decreased by the use of vasodilator drugs, which we'll touch on briefly, and also anything that will reduce the systemic vascular resistance or the peripheral tone, and that can be affected both by disease and drugs. Okay, so don't panic when you look at these graphs. They're just here to try and help you understand a little bit how the mean arterial pressure, the cardiac output, and the systemic vascular resistance interact. So first, the systemic vascular resistance is determined by the mean arterial pressure minus the central venous pressure, which sometimes you can regard as zero. You should have it monitored in your patient. So mean arterial pressure divided by the cardiac output. And you can see that as the cardiac output goes up, for an increase in systemic vascular resistance, you'll see an increase in mean arterial pressure. Or as the mean arterial pressure goes up at a fixed cardiac output, you will see an alteration in your systemic vascular resistance. How do we calculate mean arterial pressure? Well, it's not systolic pressure divided by diastolic pressure. It's actually the diastolic pressure plus 1/3 of the systolic pressure minus the diastolic pressure. So this patient's 120/80 millimeters of mercury, and their mean arterial pressure is 93. So that's mean arterial pressure, and here is systemic vascular resistance. So when we pull all of these things together, what does this actually mean? It's quite complex, but if you keep the basic principles in mind, you shouldn't go too wrong. So first, you know already that mean arterial pressure is determined by the systemic vascular resistance and the cardiac output. You also know in turn that the cardiac output is determined by the stroke volume and the heart rate as a product of the two. You know that the stroke volume is determined by preload, that's your venous return back to the heart, and inotropy, so the contractility of the heart. And your preload itself is determined by the blood volume, which can be altered by many things, not just transfusion, but also bodily position. You're going to hear about that in a different tutorial, but also venous compliance. And there are a number of factors that may affect any one or all of these to interact and give you the number you see by the bedside, which is the mean arterial pressure. But remember, it's not all about mean arterial pressure. You also need to have cardiac output. So that's the first part. We've discussed the determinants of cardiac output, and they relate primarily to preload, afterload, and contractility. And now we're going to go on and talk about the causes and types of shock. So first up, what is shock? So shock, remember, is life-threatening. So you need to address it rapidly. It's a condition of circulatory failure causing inadequate oxygen delivery to meet the cellular metabolic demands, needs, and oxygen requirements of the body. And it may produce cellular and tissue hypoxia. The types of shock related to what we've just talked about would be hypovolemic, related to insufficient preload, distributive, which may be an abnormality in preload and afterload, and obstructive, which can occur before and after the heart and also within the heart itself, and cardiogenic, which reflects the heart function itself. So I'm just going to walk you through this because it's quite a helpful schematic to have in the back of your mind. And hopefully it will allow you to work out what's going on with your patient when you're trying to determine one or the other. So we'll start in the middle here, and we've got an imbalance in shock of oxygen supply and demand. And we're looking here at 4 different components: the blood and fluid compartment, the vascular system, the circulatory system, and the heart itself. And here are your 4 different types of shock: your hypovolemic, distributive, cardiogenic, and obstructive. And when we're looking at a volume problem, it may be that there's inadequate volume, so it's volume loss. So that may be hemorrhagic, it may relate to burns, it may relate to diarrhea or vomiting, or it may be a redistribution or a shift. And that you may see in sepsis, in some kind of anaphylactic response, and some kind of neurogenic shock. On the bottom part of this, you'll see output, and that relates to cardiogenic and obstructive. So cardiogenic is related to the heart. You may have intrinsic myocardial pump failure. You may have tachy and bradyarrhythmias, which may profoundly affect cardiac output. You may have acute valvular insufficiency or obstruction from one of the valves, which tends to be an acute on chronic obstruction. And thereafter, you have extracardiac, which may be within the venous, the prelobe, or the afterlobe, or may indeed be determined by the right heart, for example, in a pulmonary embolism. So we've looked at determinants of cardiac output. We've been through the causes and types of shock. What about how do we assess technically and clinically perfusion? So the first thing is when you approach a patient, there's the overall gestalt of the patient. Does the patient look well or does the patient look sick? The things you'll be looking at the bedside are the heart rate. Is it excessively fast or is it excessively slow? Excessively slow, so 50, 70 or below, depends on how sick the patient is. But if you've got heart rates of 30, 40, 50, they're pathological. A tachyarrhythmia, be it sinus tachycardia or another tachyarrhythmia, may be an adaptive response to another type of shock, or it may be driving the shock itself. Then you're going to look at blood pressure. Now that can be quite contentious, and I know it's going to be discussed elsewhere in other tutorials, but you have to think about whether there's a specific mean arterial pressure or a systolic blood pressure that would fit with the type of shock you're discussing. So for example, in a patient with cardiogenic shock, if you look at different definitions, a systolic blood pressure of 90 millimeters of mercury or less is regarded as abnormal, but that may not be abnormal for somebody who's got pre-existing cardiac disease. A mean arterial pressure of 65 millimeters of mercury is targeted in some studies and some conditions, or 85 millimeters of mercury in others. So you need to think about the blood pressure in a clinical context. Cerebration is always important. If the patient is not alert and isn't talking to you, you have to ask yourself why. And of course, urine output. We're all very familiar with looking at your urine output and expecting to have more than 0.5 mils per kilogram. And if you see less than that for 2 consecutive hours, you should be a little concerned. Now we're going to look at a bit of clinical assessment of perfusion. So one thing you may see when you approach your patient is skin mottling. And this is related to heterogeneous small vessel constriction. You'll all be familiar with peripheral limbs that look like this. And there are various scoring systems that you can use to grade, but this is overall a subjective assessment of peripheral perfusion. Having a worse score is associated with worse outcomes in general critical care and in septic shock, but beware of limitations. So patients, for example, with burns or patients with different skin tones. So just be a little careful if you're not able to see what you expect to see. Similarly, when you touch your patient, a cold critically ill patient overall, they tend to have lower cardiac output and a higher serum lactate than a warm patient. But what is better is the gradient of the peripheral temperature to the central temperature. So this may be central in terms of tympanic temperature to toe gradient or fingertip to forearm. And the higher the gradient, the more likely it is that your patient has worse perfusion and more peripheral constriction. But be careful, if you have a patient who you're cooling for therapeutic hypothermia after a cardiac arrest, or you're in a cold room, or the patient is hypothermic for whatever reason, you can't rely on this clinical finding. Next up is capillary refill time. So for this, you need to hold the hand above the level of the heart. You would press on a finger or thumb, and it's until the skin blanches, and it's the time needed for the skin color to return to baseline. You can also use a patient's knee for this. There's a reasonable correlation with urine output and serum lactate, and if it's prolonged, so that's more than 2.5 to 5 seconds, depending on the study you've looked at, has been associated with worse outcomes in both septic shock and non-selected critically ill patients. There are challenges though, so the way people do a capillary refill time varies, so there's inter-rater variability, and again, there may be challenges related to skin tone if you're looking at the knee rather than the hand. Then you might move on to looking at some markers that the nurse by the bedside may show you, for example, with an arterial blood gas, and they will show you maybe the level of lactate. So lactate may be produced by anaerobic glycolysis in some patients, for example, very low cardiac output, or it may be driven by endogenous or exogenous catecholamines. So there are different mechanisms to have a high lactate. It isn't necessarily associated in every patient with a worse outcome, so you need to look at the drugs and see if some of your drugs you're giving maybe driving, for example, epinephrine. But certainly in patients with cardiogenic shock and septic shock, a high lactate is not a good thing to see. And what do we mean by high lactate? So this study looks at acute hospital mortality according to serum lactate in patients requiring vasopressors. And you've got hospital mortality at 24 hours and 48 hours. And here, look in brackets at the percentages. So less than 4 at 24 hours, 10% mortality, 48 hours, 30%. And if it's more than 8 at 24 hours, it's 53%. And at 48 hours, it's 72%. In patients with cardiogenic shock, we worry if the lactate is more than 2, that converts a significant survival disadvantage. So don't dismiss an elevated lactate. And then finally, if you're working in a unit which measures, uses pulmonary artery catheters, you can measure the balance of total body oxygen delivery and consumption using a pulmonary artery catheter. So this goes down through the right atrium, right ventricle, out into the main pulmonary artery, not used much in general intensive care units, but used quite a lot in cardiac intensive care units. And the normal is between 65 and 70%. Now, there are challenges with this. Firstly, are you using these tools? Secondly, pulmonary artery catheterization is not without risk. And thirdly, there may be different and conflicting reasons to have a high value or a low value. So if the patient has a very low cardiac output state, you might expect it to be low. But if they have a dysenergetic state, for example, sepsis, and the cells aren't able to use oxygen in the same way, that may be balanced by it becoming higher and therefore look normal, even though the patient has quite significant pathology. So be careful when you're interpreting your mixed venous oxygen saturation, and don't regard central venous oxygen saturations taken from the right atrium as an appropriate substitute. They're not the same measurement at all. Big advantage of this, of course, is you can measure the cardiac output and say whether you were right or wrong. So that completes the third part of this talk, looking at clinical and technical assessment of perfusion. Now I'm going to move on to a practical approach to the differential diagnosis of shock. So you'll remember this is the volume and this is the output, so hypovolemic, distributed, cardiogenic, and obstructive. And the trouble is that all of these conditions may result in these clinical features. So there's no one thing that you'll be able to say, this definitely means my patient has hemorrhagic stroke, shock or distributive shock or cardiogenic shock, certainly not from the end of the bed. If you read some of the textbooks, they would suggest that there may be some easy determinants. Now, you feel pretty lucky if you see a patient that obviously has sepsis. They're very peripherally dilated, they've got a low diastolic pressure, they're very flushed, they're pyrexial, and all the parameters suggest, including the history, this is the problem. And by contrast, you may have a patient who's known to have a cardiac dysfunction and they're cool peripherally and they're shut down. Usually it isn't this black and white. And bear in mind also that patients with sepsis may have normal capillary refill early on, but later on may develop very, very poor perfusion. So there's no one thing that you can use to tell you one way or another. Make the most of the history if you have any history suggested of infection, cardiac history either previous or current, any risk factors for venous thromboembolic disease, are they on long-term steroids, might they have adrenal insufficiency, any recent procedures, interventions or trauma, do they have central lines, peripheral lines, have they had a recent pacemaker, are they immunosuppressed, or have they had a recent up titration, down titration, or addition to their medications. All of these may affect your clinical picture. And then take this very pragmatic approach. So you have a patient who's hypotensive and they have signs of hypoperfusion. These are the things we've discussed. So the altered mental state, the mottled, clammy skin, the oliguria, maybe tachycardic, maybe an elevated lactate. And you're thinking this patient may have circulatory shock. Now, in the back of your mind, you should have what is common. Most of the patients will have distributive shock. That's about 60%. About 16% will have either cardiogenic or 16% hypovolemic, and very unusual is obstructive shock. So when you approach the patient, have this in the back of your mind. Then you can either estimate the cardiac output or the mixed or central venous oxygen saturation. And if you think these are normal or high, what ideally you'd like then would be to take a look at the heart and do either a focused cardiac ultrasound scan or ask somebody else who can what the heart looks like. If in this clinical context the heart has preserved or hypercontractility, this confirms you're likely to have distributive shock. If by contrast you've got an estimated low cardiac output state, or your mixed venous oxygen saturation is low, look at your central venous pressure. It's a wasted number if you don't look at it. If it's very low and you do a focused cardiac ultrasound scan or an echocardiogram, and your heart shows biventricular hypercontractility, it may be that you've got hypovolemic shock and you've lost plasma or blood volume. If the venous pressure is high, you've got low contractility, this is cardiogenic shock, and then otherwise you start looking for signs of obstruction. Be mindful though that patients may have more than one type of shock at the same time. The other thing is, as you're approaching the patient, don't forget your ABC, airway, breathing, circulation, resuscitate the patient. Now that may be with volume, it may be with ventilation, or it may be with inotropes or pressors. Always think about diagnosing and addressing the underlying cause. So somebody with shock and a big right heart and a leg that looks like this, you should be thinking about DVT and pulmonary embolism. You need to monitor the patients and you need to repeatedly reassess. So that now brings me on to the very final part of my talk, which is about how inotropes and pressors work and what they do to cardiac function. So this is just for you to reflect a little bit, because people get a bit anxious when we start talking about inotropes and pressors and cardiac function. So ask yourself, have you ever received any training in the use of vasoactive agents? Well, if you've ever done any resuscitation, the answer is yes. You probably used adrenaline during a cardiac arrest. When would you use a vasoactive agent in your practice? Well, you might use it in cardiac arrest or in anaphylaxis, but related to this in particular, related to hypotension and shock. Think of yourself as a novice intensivist. Have you ever heard of any vasoactive agents? Yes, of course you have. Many of these would be very familiar drugs to you. So dopamine, norepinephrine, epinephrine, dobutamine and milrinone, and then some newer drugs which we don't really have to worry about because we don't generally use them in patients who are very shocked and acutely unwell. And what types of agents do you know? Well, you do know this already. You know there are inotropes that increase contractility. You know there are vasopressors that cause vasoconstriction. And you know that there are inodilators that have an inotropic effect, but also may cause vasodilatation. So these are familiar drugs to you. Just think a little bit about now how they work. I don't want you to worry about this too much, other than to say some of them work via beta adrenoreceptors. Some of them, such as milrinone, are phosphodiesterase inhibitors. And then there are some newer drugs that work directly on the myocyte. Remember also that inotropes and vasopressors, even though we're fixated on the hemodynamic effect, they also have other effects. And they are a very diverse collection of molecules. They have very different pharmacological properties. They have some shared activities, only one of which is positive inotropy, but many of these effects may be adverse in terms of a patient who has shock. So when you're looking at what your more senior intensivists are picking up and choosing, it may be they've got these other effects in their minds when they're selecting their inotrope or pressor. This is the sort of table that we're given to learn, and I find it very, very hard, if I'm not using these drugs all the time, to remember these effects with respect to receptors and to remember what the effects are with respect to what they do to the heart and peripheral circulation. So I'm going to give you a slightly easier schematic that I hope I can walk you through, and it will allow you to remember it in a way that is very practical by the bedside. So first up, we're looking at our alpha and our beta receptors. And if you move from alpha to beta, you have more effect on the cardiac output. And as you move from beta to alpha, you have more effect on the blood pressure. So if we look at drugs at the extreme, so phenylephrine is pretty well entirely an alpha agonist. It increases vascular tone and blood pressure. It can decrease cardiac output by increasing the afterload, and it can impair the blood flow, particularly hepatosplanchnic. Right at the opposite end is isoprenolone or isoproterenol. This is a beta agonist. It's limited to use in profound bradycardia for short periods of time because it does cause profound tachycardia and it has potential to cause myocardial ischemia. So those two drugs are not really ones that we would reach to first line. What we would reach for is norepinephrine or noradrenaline. So norepinephrine has a predominantly alpha effect, a modest beta effect, and that little bit of beta effect may give you a bit of positive inotropic activity. So you will see an increase in blood pressure, little change in the heart rate or cardiac output, and the doses that you would use would be sitting here. Now, this is a three-way graph. So you've got vasoconstriction at the top, that's your alpha effect. You've got positive inotropy here, which is your beta effect, and you've got vasodilatation. And you can see that norepinephrine is lovely. It's got a little bit of positive inotropy, and it's got a decent amount of vasoconstriction from the predominantly alpha effect. So there's norepinephrine, your first choice constrictor. Then you will hear people talking about giving low and high dose dopamine. So the reason people have historically liked dopamine is you can give it peripherally, so it's a quick and easy drug to give. And it does have theoretical benefits, but it does have its downsides. It's got potential to inhibit the neuroendocrine axis. And when you look at trials, a sub-study of a sepsis study showed that in patients with cardiogenic shock, it's associated with more arrhythmia and possibly an increased mortality. And for that reason, and for other small studies, also in sepsis, it suggested that we should not be reaching and recommending the use of dopamine as our constrictor of choice. Then we can look at epinephrine, either in low dose or high dose. It's got a beta effect at low dose of lots of positive inotropy, more alpha effects and more constriction at the high doses. It can be profoundly arrhythmogenic. It does reduce blanklet flow. It may be associated with harm when used in shock, and you should only reserve it for when your patient is really, really sick and for the shortest amount of time as possible. And it should really only be used by people who are really intensivists. I'll briefly mention vasopressin because some people may reach for this. It's a bioactive nonapeptide. It's safe. It's got no demonstrable major benefit over norepinephrine. You should use it only in a very, very low dose. In theory, it may be a pulmonary vasodilator or at least less of a pulmonary vasoconstrictor at very low doses. But again, it's something that's really reached for as a second line dose. Now we're going to move to inotropes. So dobutamine here, so you see we've moved up on your cardiac output and beta effects and lesser on your alpha effects. Dobutamine should really be regarded as your first line inotrope of choice. It causes less tachycardia and arrhythmia than isoprenaline. Use the smallest dose you can, up to about 20 micrograms per kilogram per minute, and adjust according to effect. And you may see no change in blood pressure. You may see the blood pressure goes up a little bit, particularly in patients who've got a very constricted periphery, they've got poor cardiac function, or you may see that the blood pressure drops marginally if you've got a patient who's a little bit vasodilated. So always monitor and make sure you're getting the effect that you want. And then finally, there's milrinone, which is a predominantly PDE3 inhibitor. It decreases the metabolism of cyclic AMP and may therefore potentiate the effects of dobutamine. Be careful when you're using milrinone. It's got a slightly longer half-life than some of the other drugs. And if you cause hypotension, that hypotension may be problematic. So when I look at how I'm going to use vasopressors and inotropes to affect cardiac function, I think about why I'm doing it. What am I trying to achieve? Is it pressure? Is it flow? I think about titrating it to get the effects I want, but to use the lowest dose for the smallest time possible. And I look to wean as soon as possible. So just finally, to recap what we've done, you should now be able to discuss the determinants of cardiac output, including preload, afterload, and contractility. You should be able to list the causes and types of shock: distributive, hypovolemic, cardiogenic, and obstructive. You should be able to now describe your clinical and technical assessment of perfusion, thinking globally, peripherally, and thinking about the laboratory investigations you may get. You should have now at your fingertips a practical approach to the differential diagnosis, which encompasses the history, the examination of the patient, and certain investigations, bearing in mind also to be careful you may have mixed shock, and also remembering that the most frequent shock that you're going to see is distributive. And then finally, in a very simple way, but a very practical way, you should be able to explain how inotropes and pressors work and what they do in terms of cardiac function. You should be thinking about beta versus alpha gradients. You should be reaching for norepinephrine for your first constrictor of choice, dobutamine for your first inotrope, and remember, institute, titrate, and monitor. Thank you for your attention.
So thank you very much, Professor Susanna Price. It was a very nice overview of this important context of the essentials of the cardiac function. One of the things that comes in my mind is you discussed cardiac output and what is the way to interpret cardiac output, and especially if we think at patients who are in difficult state, and especially sometimes with COVID-19, with some hypoxemia, sometimes some bleeding, hemorrhage, and so on. So how do you interpret cardiac output? What is a good cardiac output? How do you decide to use or not inotropic agents in these kind of patients?
Okay, so I mean, that's obviously an excellent question. So if I think particularly about the COVID-19 patients, they are a little more complex because there is certainly in our patient population, and that described in New York, a very high incidence of pulmonary embolism. And you may see that your patient is hypoxic and they have a relatively low blood pressure, and you volume resuscitated them, and maybe you thought they were a bit peripherally dilated, so you've given them a pressor. I think that the thing that you should be doing then, if you're not got a patient that's got a nice low lactate, they're making plenty of urine, they're nice and warm, you need to look at the heart. Because if you look at the heart using an echocardiogram, you may see that they have left ventricular dysfunction related to sepsis, or they have a right ventricle that's dilated and poorly functioning, in which case you should be really strongly thinking about pulmonary embolism. Do you need to exclude pulmonary embolism as a cause, CT pulmonary angiography, and treat that obstructive shock? But then they may well have a combination, and I think it's very hard to say one number because a number of a cardiac output index in a patient who has underlying cardiac disease and then gets sepsis on top, they may not be able to mount a very, very high cardiac output index. So again, when you look at that heart, you would expect in a patient with distributive shock to see hyperkinesis. You would expect to see normal or supranormal ventricular function. When it's not normal, you then have to say, is this cardiac output enough for the patient? So are there markers of hypoperfusion? So is the lactate participation olivuric? If that is the case, and you've shown that the heart isn't functioning normally or not supranormally enough, then I would be thinking of adding in an inotropic agent, unless there was an underlying cause that I could treat. Does that answer your question?
Yes, and I think that we may also add probably as you mentioned initially in your talk, the use of the capillary fill time as also an indicator of tissue perfusion, and when you give your inotropic agents to indeed see that this improves or not. One question that I would have, a practical question regarding the way you titrate your different therapies. You mentioned inotropic agents on one hand and vasopressors. So let's begin with vasopressors. How do you manage this at the bedside? Do you try to use huge doses and then to decrease it slowly, or you go step by step, or you adapt yourself to different type of patients?
I adapt myself to different types of patients. So it depends how catastrophically sick the patient is. If I'm facing a patient with a systolic blood pressure of 48 or 52 millimeters of mercury, and it's on a massive decline, and we're giving volume and we're resuscitating the patient, I may be quite aggressive in what I give the patient in terms of pressor. And at the same time, I'll be looking at the heart and saying, okay, is there a requirement for an inotropic agent as well? If it's just the patient is borderline hypotensive with a slightly low urine output, and I've done what I would want to do in terms of volume resuscitation, I would come in with a very, very low dose, as low as possible, and see what the response was. And once the patient has stabilized, I would always be looking to reduce. Now, that's in a patient with, in effect, a normal heart. When you've got patients with complex heart-lung interactions, which are going to be addressed in a different tutorial, or patients who have profound right and or left ventricular dysfunction, then I choose my inotrope, my agent, depending on what I want to happen with respect to contractility in the afterload. So, for example, if I have a patient with profound right ventricular dysfunction and I have a high pulmonary vascular resistance, and I need to maintain a perfusion pressure of the aortic root because the patient has this pulmonary hypertension, then I would be using vasopressin with its potential slightly beneficial effect on the pulmonary vasculature to support the dose of norepinephrine I've given rather than going very high. And I would also be looking to see what pulmonary vasodilators I could give. By contrast, if I've got a left heart in a patient who has ischemic heart disease, I try very hard not to give milrinone because we know it's associated with long-term adverse outcome. I would use as low a dose of dobutamine as I possibly can. And if the patient would need revascularizing, I would be looking to do that. Having said that, very difficult to do in your patients with COVID-19 because you have to be very certain that your dual antiplatelet agents, if you put any stents in, are going to be absorbed, are going to be effective, especially in a patient who may be pro-thrombotic.
So thank you very much. This was very informative, and now we will move up to the next speaker.